welcome to week 4. You're halfway through PCS, that is. So I had a call with one of my students, Sharon, over the last week. I guess it may be this week. I don't know. It's been such a long week with all the moving and stuff. And she asked me, what advice would I give for beginning coders? And so I thought about it, and, my initial answer was, let me describe to you the different types of coding. So you have doctor's office coding, which I don't know anything about. I've never done that before. You have, in the hospital side, you have ancillaries, which are like labs and radiology, and all you code is basically, if, let's say you have a cough and the doctor wants to make sure you don't have pneumonia, they send you to the hospital to get a chest x-ray, and so it, your diagnosis going over is cough. Then with, let's say that the x-ray shows nothing, you don't have pneumonia, then you would code cough. So that's ancillaries. It's basically, very cut and dry, very, beginner. Alicia, I don't know what's going on with Alicia. So that's, with the ancillaries, that's what it is. Then you have ERs, which are probably the second easiest. And that is where, a patient comes into the ER, let's say they cut their finger, washing dishes, for example. So they go to the ER and, they, suture them up. You close. I'm reading you're all talking between each other, sorry. You'll code, the diagnosis, the laceration, and then you will code the suturing. And so it's usually with ERs, these are ERs that when they're discharged, that's what you would code. Now, the next one would be same-day surgeries. That is, basically, tonsillectomies, hernia repairs, but they're doing so much more now in day surgery. Yes, ER is the same as ED. It's emergency department versus emergency room. I'm just old school. And then you have inpatient, and inpatient is the very, very hardest. I've coded charts that are, patient's been in-house for 6 months. And, you have to read all the progress notes. You have to read, all the surgeries, or if any surgeries were done. It requires a very different, type of individual to be able to do that. So, with that said, my suggestion is, decide what you want to do. Do you want to work, well, first off, let me say, if you have no experience and you're not in healthcare at all, I would say that what you need to do is get your foot in the door. And, once you get your foot in the door, they are more likely to hire from within than they will, hire an external person. I've been in a management position where I had a guy who had been, doing work. Actually, this is old days, so there were records, and he was assembling ER records, but he had a real big desire, to learn coding, and he had gone to school. No, not necessarily an internship with a hospital. That's more of a, I just mean get your foot in the door. Like if HIM will hire you as an analyst or as a, or if you want to go in the doctor's office side of things, have them, maybe you can do something, work the front desk or something like that. Yes, so entry-level position. So I posted one of the attachments that for this week. It's called the Top 10 Cringe. And I'm going to share my screen. And so with my class, I shared it last week, but I wanted to share it with everybody. This is, I didn't write this. This is a blog, Coder Coach blog. And it's, goes through what the top So that's, you have to, the thing about coding is you can't go into it just for wanting to, make money and my second part will get to the working at home as well. But you got to do what you really like. And is it cutting out? I'm sorry. You may have to listen to the recording. I don't know what's going on. I apologize. Sorry. I'm not moving, I promise. I apologize. You guys may have to listen to the recording. It's, I promise you I haven't moved. My head has moved, but that's it. So I apologize to everybody. I don't know what the problem is. I'll try to make my connection better. Okay, let's try again. So what type of coder pays the most? You want to make sure you do what you love. You don't want to do something you hate. Should I be a hospital or physician coders? So again, this is something you have to figure out. You've got to decide, what do you want to do? No one will hire me with the coding credential I have. They all want something else. And so basically, what she's saying is, do your homework and, look for what's out there. What are they looking for? What are you wanting to do? What are you looking for? Where can I get free continuing education credits? They are out there. Definitely. Janice, yes, inpatient does pay more. That is true. You're only eligible for the CCA. You can sit for whatever one you want to sit for as far as the coding certificates. However, with CCS, they recommend you have 3 years of inpatient experience. So with the CCA, honestly, you may be able to get, for a long time, nobody was hiring CCAs. But, if another suggestion I had, and that I just told Sharon and I just now remembered, was, start at a smaller facility. So if you have, like a community hospital, I started out in a community hospital, and that's how I learned to code inpatients. I learned to code outpatients. I learned to, do birth certificates. I learned to do, pull charts for doctors. I learned to, do analysis. I learned it all. So, you can get a whole lot more experience if you're in a smaller place. Now, say I can't afford to join a HEMA or AAPC. Honestly, you have to be a member of a HEMA. At least I'm not a member of AAPC because that's viewed more on the physician side, but it's fine either way, but I'm a member of a HEMA. I can't have my credentials without being a member of a HEMA. So you're going to have to be a member. And my thought is, or my suggestion is, make sure you, I would join as a student. It's super cheap as a student. Now, once you become, you know, like me, then you pay for the credentials that you have, and you know, and it helps. It pays. Well, it pays for some of the CEUs, or your credentials, and then you have to take certain, you know, tests and make sure you. Yeah, $35. That's great. So that's, yeah, I definitely recommend it. It has a lot of great information there that you can use. So, you know, I highly recommend that. This is my second or third career. I can't afford to start at the bottom. This is one that, you know, honestly, like I was just saying, you have to start at the bottom. You can't just go in there and you know, after, you know, it's honestly, after 26 years, I learned something new every day. And so, you know, I just want to say, you know, most people have to start at the bottom. And it's unfortunate, but it's still true. Will you mentor me? This is more of her personal thing, you know. It's basically, you know, a lot of people, I don't get asked for mentoring. I do get asked for references, though. That's the one thing I do get asked for, but mentoring is not one of them. Because unfortunately, with online schooling, and also with online coding, there's really not a lot of face-to-face. And so it's a little bit harder to mentor. And June, that's great that you're a clinical analyst. That's perfect. You know, so that is the way to get your foot in the door. So definitely. I went to school for whatever, that many months, years. I'm certified. I'm qualified to be a coder anywhere. That's not true. Just like what I just said, I've never done physician coding. I hate E&M with a passion. Sure, I would definitely, if a HEMA offers mentoring for members, I definitely would recommend it, definitely. So you want to, you know, you're not, people become, you know, you may be qualified to, you know, code inpatient or to code outpatient or to code inpatient and outpatient, but it is not, you know, it's nobody really has a complete encompassness of all of the different types of codings. There is interventional radiology coding, which is another one I won't touch with a 10-foot pole, you know, which has to do with CPT, and it's all the, you know, it's just way too much for me. But, you know, don't feel like you, you know, that you know it all. And then two, how can I get experience? If no, we'll hire an experienced coder. Again, I don't, I'm like her, I don't have the answer to that. My opinion is just go in and you know, there is, it requires a ton of dedication, a ton of discipline. It's, it's very, you can't watch a child, especially one that's not self-sufficient or that's not in school, for 8 hours a day, and work. Introvert. I can be an extrovert, but and I had to bring them back into the hospital. So if you don't do what you're supposed to do, then you're going to be in trouble. And Amanda, to answer your question, it's not necessarily bad. You just need to have a real desire to do it, and a real desire to learn. It's, is it something, my father was a doctor, my mother was a nurse. If I could have stood, if this makes sense, the vomiting, the stinkiness of people, I'm great with the surgery, and I'm great with, once they're in there, all that, but I don't want to deal with a sick person. And so that's why I couldn't go into, being a doctor. That's, what I really wanted to do. So, but I have a passion for medicine. I have a passion for learning. That's kind of, how I got into it. So, does anybody have any questions about that? About any of the reality I've just placed on you? And again, it's there for you to download. It's just a blog that a friend of mine who's a coder, that she sent to me, and I thought it was good. It's very honest. And this is great. This is such a coder. I'm not arguing. I'm just explaining why I'm right, because we will argue all the time. Do the HIT? Yes, they work through the weekend. Yes, they do work through the weekend. If Aisha, if that was your question, hold on. Y'all type so fast. Yes, they do work through the weekends. It's open. HIM department has to be open 24/7, 365 days a year. There's 3 different shifts. In some smaller facilities, there are, and things have kind of changed since, there's electronic health records in some places. But, with back in the day, there was always somebody on call. If, like at the little facility I talked about I worked at, I had a pager, I had a pager, or, excuse me. And so hours worked, you can work first shift, second shift, third shift. And, that depends on if they have a third shift. Okay, I'm trying to see the funny comment. Hold on. I must have missed it. I guess, yeah, I'm a surgeon too. Everybody I know calls me for medical information. That's funny. Yes, and Lisa, that's very common, 8 to 4:30. It's, in all honesty, like in the bigger hospitals here in Dallas, it is 24/7. There's, somebody is there at all times. So it just depends on the size and how needy is the staff, if they can function without you being there. So, a lot of coders prefer to, I'm sorry, I'm trying not to cough, sorry about that. A lot of coders are, they'll start at 4 a.m. But as far as no experience in coding, but she was trained on the job, it does happen. It's, they have, there's some places that have what's called grow your own coder. And, that is kind of where people, especially in the rural areas, are having a lot of problems getting coders, because what happens is, once they get a few years experience, then they want to become a consultant, because consultants make more money, and can still work from home. So what they're wanting to do is, they want you to, they're losing all these coders, basically, is what I'm saying. And, once they lose them, then they can't get them replaced, because in the rural areas, it is, it's just harder to place them. No. What I learned in school meant nothing in my coding career. I honestly learned on the job. Yeah. But see, I try to teach you all a little bit, I attempt, much so more in the 205 on the coding guidelines, because you can pick a code all day, but if you don't know, the coding guidelines, yes, definitely, especially for the RHIT exam. It's, that's what you're going to be tested on, or the guidelines. It's not going to be about finding a code. So, I definitely suggest, guidelines. I definitely, if you can find somebody, RHIT comes first. RHIA is the 4-year. So, any other questions? Anastasia, I felt that same way. Though I didn't have a 4.0 because I made a C in freaking coding. Yes, Dawn. No, I don't think coders will ever phase out. K Cert are, they are overrated. And Donna, yeah, we're going to go over it definitely, but you can go ahead and ask it. That's what I was going to do next, actually, but you go right ahead. But CACs are going to, CACs are good for minimal integral symptoms with a diagnosis. So what you code is you code the appendicitis, and then you would code the appendectomy. Well, with a CAC, they want to highlight and try to have you coding the nausea, the vomiting, the right lower quadrant pain. They don't understand that you don't code those, and so that's why I don't think coding's ever going to go away. There's no possible way that a CAC could find a PCS code, not to my awareness. I can barely find it, and I'm a human. So I'm talking, the computer-assisted coding. I'm sorry. I'm talking about, will coders ever phase out? Kind of like, yeah, I'm sorry. I was just using my lingo and not thinking. Computer-assisted coding, I don't think coders are going to phase out like transcriptionists kind of have. I mean, to a fairly big majority. I don't think it's going to be in my lifetime. So, for sure. Okay. So y'all ready for the coding roundtable? All right. Oh my goodness. See, there was a question, and then how do you separate which procedure goes with each code? It just takes a lot of practice. you in all honesty, when Dr. Campbell developed the PowerPoint, and it does a lot of root operations, though they may not all be relative. I promise you, the root operation becomes the hardest thing to grasp. And so that's why practice is so important with that. It's not that hard to, find what body system it is. Well, sometimes it is, but I had one today that was. But it's more of what are they doing. So how do you get more than one code at a time? Actually, June, I'm going to show you there's going to be 3, and actually I prefer that there's 5. So let's go through it. Let me pull up 3 of them real quick. Hold on. I don't do it because I'm afraid somebody's watching for the first time and they're not going to know how to get into iLab, so that's why I do it this way. Okay. Aisha, I promise you I'm not moving. You know what, Mark? Okay, I'm going to give you my reasoning, and you can take that to the professor, because I argue this every time. But what? And I will. Aisha, that's greatness right there. It is, they can get to where they need to go. So, you don't have to worry about, they're still at this point, they're unable to find the parathyroid gland at that level. We then subsequently freed the pole of the thyroid gland, and we started identifying the thymus tissue. Yes, clear the operative site. Great point, June. So here's our first thing that they actually did. There was a right neck lymph node that was submitted for frozen section, and this was benign. So let me explain what a frozen section is. And the only reason I know is because my father was a pathologist. Well, that may not be the only reason I know, but it's because my father was a pathologist, and he raised me growing up. So a frozen section is done during surgery when they want to know immediately from the pathologist if something is cancer or not. So what they do is they take it out. It's immediately taken to the pathologist while the it's basically a special type of section where it's called a frozen section, and determine if it's cancer or not. So, oh goodness, can you hear me now? Oh no. No. hear me? Hello, 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 hello. Sorry about that. I hate my computer. I was trying to push in my cord thing and it was me, but I turned it off. Okay. So we have, the first thing they did was the right neck lymph node biopsy that was submitted for frozen section. I'm sorry. I can be very, very technically challenged at times. Oh, no screen. Okay, thank you. I'm trying to share it. Give me 1 second. Here we go. There we go. Yay, okay. Perfect. So the first thing we have is there was a right lymph node that was submitted for frozen section that was benign. So, and again, everybody has parathyroids and thyroids, so I'm not changing this and I'm just putting in an age. It doesn't matter unless it's a male or female procedure. So they did an excision and they didn't do a total body part because it was a lymph node. So the lymphatic and hemic systems, and it was in the neck, and that I need to, I'm assuming it was left. Oh, I didn't click continue. Wait, hold on. Let me go back, because maybe it wasn't in the left neck. Give me 1 second. See, I'm only on one screen here, so was it right? Thank you. There it is. Sorry about it. Thank you. Okay. And then it was done open, and it was diagnostic. And so ignore the I-9 code. So you have excision of right neck, lymphatic, open approach, diagnostic. So any questions on that one? Awesome. Okay. So here's where we're going to differ, right here. We have differ from, meaning there's different, I've put in my 2 cents on this, but let me say that the only time you use the multiple is if you don't know what exactly was excised or done or anything. It's a coding guideline. They say you don't, if you know what is done, or if it's the same example for burns, and of course that's a diagnosis, but if they say multiple burns, you don't code multiple burns. You code the burns, especially if you know exactly what each one was. The code was 07B10ZX. So that is my argument on this, and I stick to it, and you can tell the professors that is my argument on this. So they took out 3 parathyroids, okay? they did, let me get to, okay, so there was we identified the right lower parathyroid, and then they actually did, so they did the right lower parathyroid gland, and that was, the lower also means inferior. And then this was, I'm sorry, that one was just partially done, because it says the proximal half of the parathyroid was left intact. So let's do that code. So excision, so it's not the total body part, and it's going to be other specified. This is the parathyroid. Hold on one second, because maybe what are your all's thoughts on what the body system should be? I know, but I'm just asking. Very good. Endocrine. So they did the parathyroid gland. See, this is where you have the choice to choose multiple. To me, it's not as specific. If you know what parathyroid gland was done, then that's what you're going to do. And in this case, it was the, of course, why is it right in lymphatic? I mean, I'm not sure I understand the question. The first code, because they took out the lymph node. The lymph node is lymphatic. That's a lymph node. This is a thyroid, and so it's an endocrine. It's two separate body systems. And inferior parathyroid gland was on the left or on the right? Was it on the right? See, yes, I can do the book. Thank you, on the right. And it was open, and it was, in this case, no qualifier. So excision of the right inferior parathyroid gland, open approach. Verlin, I'll do the book as soon as I finish doing it this way. Okay, so our next one was the left strap. This is them just getting to it again. The nerve was found. The left upper parathyroid was identified. We freed it from the nerve and from the thyroid gland. It was confirmed to be parathyroid tissue. Small vascular pedicles were clipped, and the left upper parathyroid gland was removed. So, left upper parathyroid gland. So, even if I do excision here, it's okay, because it's going to give me total body part. The thing to remember is a parathyroid is actually a total body part. So again, we're going to go endocrine system. Then we're going to go and see as quickly as that. I forgot. No. Right lower okay, so inferior parathyroid gland left. It was open, and so we have a resection of the left inferior parathyroid gland, open approach. All right, so what's going on next? Give me one, keep clicking on the wrong thing. There we go. Let's see, the left upper parathyroid was identified, found to be posterior, and measured. We freed it from the nerve. It was confirmed to be small vascular pedicles. Okay, so the left upper parathyroid gland was removed. The whole thing was removed. So, resection, endocrine, superior, upper is superior. Oh, I'm sorry, Janice. Yes, I will. I'm sorry. Here, let me go back. So even though I know it's resection, I'm going in as excision, because sometimes if you type it in that way, it makes it a lot easier to it makes it a lot easier to find your code. The third one was resection of the left inferior parathyroid gland. So that's where, right here, they identified the right lower parathyroid gland, and then they took it out. So that's what that one was for. So I'm basically doing exactly the same thing I did for number 3, but I'm doing it for the next one. And because they took the total body part out, Dawn, you're going to have to learn to use it in 205. You can not use it now, but you're going to have to learn to use it. Okay, so resection, and again, this was endocrine. And then this was superior, and of course, and left. Superior parathyroid gland left. They did it open approach. They opened them up. So resection of the left superior parathyroid gland, open approach. And let's go to the next one. We ligated the superior thyroid. This was done. Mobilized the gland, not finding any parathyroid tissue superiorly. We then addressed our attention inferiorly where the thymus was pulled out. We identified left inferior parathyroid gland. This was found to be anterior to the nerve. This gland will be noted. This was removed in its entirety. So the left inferior, though I thought I already did the left inferior, maybe I should have done the left superior. Hold on. I did the left inferior. That's what I thought. Hold on. I'm just reading, so give me a second. Right, the lymph node, the proximal half of the parathyroid, so thyroid, the middle, and divided. Nerve is found at the base. Left upper. Okay, so I did the left upper. And I did the left lower. Okay. So that's still not, give me 1 second. Thank you. Second paragraph. See, it's 2 inferior thyroid artery branches were ligated, and blah, blah, blah. Middle thyroid vein was ligated, thyroid gland was mobilized medially. The right upper parathyroid gland was found to be in the mid aspect. The right, so that's the right upper. And then we have the left lymph node. Oh, the right upper, that was the, hold on. Okay, so I got right lower, I don't have right upper. That's it. Oh, wrong one. So resection, it was a total body part. I think they did find it. Hold on, Dawn. There were 2 NOCs. Yeah, here's the posterior, let's see, the right upper parathyroid gland was found at the mid aspect of the posterior thyroid, and then it was slowly removed from the thyroid gland vessel and blah, 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 blah. Oh, you were talking about the left. Hold on. They did find the right upper left, the left superior. Hold on. I have the left upper, the right lower, so then we have left lower, so I have left lower, left upper, and then I have the I'm reading. I've done this a million times. I don't know why First sentence of last paragraph. We ligated the superior thyroid vesicle. No, that's not the one. Right lower was the biopsy. Okay, hold on. Let me go back. Right lower was the biopsy. Left lower was that one. Open, and then so they did 3. And then there's another one. I think that the one, hold on, left upper I had the left upper. So I have left upper. Dawn, where are you seeing that? I'm not seeing that. Let me go back to the. Which side are you on? The left side? Anastasia, no, we're not doing the gland. Left superior. I have both upper and lower, so there's no superior. Okay, hold on. That's what my issue is. Okay, let me go back. So there's no, so we need the right upper and not the left upper. Correct? That's where I screwed up. Okay, perfect. Dawn, I'm listening. And no, y'all aren't going to see these. Or maybe you might. Nope, you're not. I'm trying to see what they have in here because the right and left upper and left So they did right, here was the right upper, so they got right upper, right lower, and then they did left parathyroid gland was identified, found to be posterior, so Don, you had me confused. Thought I didn't know what I was talking about. Okay. And then there is an additional code. And this one is for, okay, so 3 parathyroid glands, the right, the and left upper superior, and the left inferior. So I need to do the left inferior also. That one was excised. That's other. It's going to be other. And again, this will be endocrine. And so that one, the one that I missed, right and left upper superior. So I need the right superior upper. Again, it was open, no qualifier. No. Ignore that. Sorry. Excision, which it was total resection. I'm sorry, I chose the wrong one. Of the endocrine. And Michelle, I'm sorry, I'm not trying to jump around. I'm trying to figure out where I'm at because I'm getting questions and I can't, I'm trying to read it on one screen. And if I could put it on my other screen, it wouldn't be a problem, but I'm trying to get back and forth, back and forth, back and forth. Superior right. Mark, you're saying it's lower right? See, this is why I'm getting confused. Hold on. I know I just had superior right. So right and left upper superior and left inferior. Right and left upper superior. Okay, that's it. Okay. So this is the reason why so the consensus, so if you use what is in the let me say how to say this. If they're going to strictly say that there's strictly 3 codes, then what you'll do is resection, and instead of coding these last 3 codes, you'll code resection. It's a total body part. Again, it's endocrine. And then parathyroid glands multiple. Again, I totally disagree with this completely. And so that would be your code. I think it's lazy coding. I think it is, you are, I would count it wrong if I was auditing it. Yeah, so it would be, if you're going to go with what the professor says to try to get them right, it would be these 3 and not these 3. If you want to be totally correct, then you don't code that one, that one I just added. That's just my opinion. I have voiced it on multiple occasions, so it's, it's okay. No, I wouldn't count it wrong on a test. Alicia, no, you wouldn't code that one. I don't care. You can code multiple if you want to. I'm not going to count it wrong. I think it's lazy coding if you know exactly what's being done. Katrina, yes, it would be 5. And Dawn, yeah, it's okay if like I said, I've had, with the other professors, we've had banter about it. It's all good. That's one thing about us coders. We all think we're right. So, and unfortunately, due to time, and I apologize for my momentary, disabling my own computer. But if, what I suggest you do is go into this, week 4 live lecture that is attached in the files right above where you're typing, and download it, and that way you can have it and practice the root operations. Michelle, that's my opinion. Again, only an opinion. I think that these are the correct 5 codes. I think that this is lazy coding, and you would, so. For me personally, yeah. Oh, not Anastasia. Yeah, that's the. Yes, those are the 3 you want. Again, in my class, I don't care as much about you having the right answer as trying. So, because it's it's all about learning. So. But guys, it usually doesn't affect reimbursement. Normally, if this is done as an outpatient, it's paid based upon APCs, and that's it's based upon CPTs, and then well, with this it would be an inpatient. So I'm just thinking it through. It's not going to affect it. Will it be wrong? No, Dawn, it wouldn't be wrong. I just think that it should be, if you know what's done, that's just kind of the coding guideline, as you code it to, as far as you can. That's, that's my opinion, and I've voiced it. Yes, you do code what you know. That's correct. So any other questions before I let you guys go? Sorry about the computer stuff today, and I'll try not to bounce around so much. I'll try to. It's hard when I only can work with one screen. Okay, guys, thanks so much. I hope you guys have a great week, and I hope that everything goes great for you this week. And I appreciate you listening. Thanks.